This is ACEP President-elect Ryan Stanton inviting you to join me at ACEP 26, October 5th through the 8th in Chicago. Your specialty, your people, in one place. Register now at acep.org/acep26 and get free access to ACEP anytime. I hope to see you in Chicago.
Your first patient of the day has non-specific symptoms and you're like, oh, it's just a viral illness. It's, non-specific. But then you think, could this be the beginning of a biologic warfare?
At the same time, EMS brings in a young woman who was found unresponsive at a party. Her clothes are partially torn and she has no memory of the past several hours. And you wonder, do I have to worry about the patient having been sexually assaulted, and how should I approach evaluation of this patient?
In this episode of Critical Decisions in Emergency Medicine, we will talk about identifying illnesses of bioterrorism and how to manage them.
We will also talk about evaluation and management of sexual assault patients and specific medical legal considerations.
With you is Dr. Danya Khoujah. I'm an emergency physician who practices in Florida and all over the world.
And this is Dr. Wendy Chang, an emergency physician and neurointensivist in the Baltimore, Washington region.
And this is the June 2026 episode of Critical Decisions in Emergency Medicine podcast. Each month, we discuss 2 lessons that are bread and butter emergency medicine, or things that are cutting edge.
In addition to the 2 lessons, there are also a lot of other features, such as the Clinical Pediatrics, the Critical Procedure, and the Critical Image.
And for our first lesson of this issue, Safekeeping, Evaluation and Management of Sexual Assault Patients, thank you to Doctors Heather Rossi and Ralph Ferviello for writing this article. Wendy, sexual assault is a very important topic that we have variable experience with, depending on the availability of specialized clinicians, such as sexual assault nurse examiners or sexual assault response teams in our emergency departments. And therefore, our familiarity with the details of how we should care for these patients can be quite variable and sometimes deficient when we move away from intensely supported environments to those that are less supported.
Absolutely. So this is definitely a great lesson for everybody to review. And in addition to certainly the standard medical care we provide for the patients, as well as the specific evaluation and management to the sexual assault itself, we have to remember we have to provide a trauma-informed care and consider the potential sequelae of the patient having experienced such an event. And in general, in terms of how prevalent this is, certainly it is still often underreported. And even despite that, data suggests that more than 45% of women and nearly 17% of men in the United States have experienced contact sexual violence in their lifetimes.
That's a very sobering and concerning statistic. Are there any misconceptions out there that we need to dispel when it comes to our understanding of sexual assault?
Perhaps some may envision sexual assault occurring in a violent act with an unknown perpetrator, but we actually know that most of these events are committed by perpetrators known to the victims. And a common misconception is that the primary motivation is sexual gratification, where in fact, perpetrators often rape their victims to exert power and control and take away the right to consensual sexual activity. In addition, don't forget, as I mentioned, that 70% of men have experienced sexual violence in their lifetimes. And we also know that male sexual assault patients may actually be at higher risk of serious injury than female patients. And then thirdly, even if on examination you don't find physical signs of assault, this should never discount the patient's disclosure of such an event and should be evaluated thoroughly.
Such great reminders. So we were talking earlier about the presence of support in our emergency departments and SANEs and SARTs, sexual assault nurse examiners and sexual assault response teams. What is their role in our emergency departments?
Yeah, if you have access to these particular specialized clinicians and multidisciplinary teams, they're obviously a great resource. And the benefit of having a SANE is that they can provide this thorough evaluation that can be time intensive, and they have very clear defined protocols. And really, that also leads to more effective prosecutions of the cases. And the particular sexual assault response teams, as I mentioned, are multidisciplinary because they really can include a variety of members, including patient advocates, protective services, law enforcement, and really addresses the multifaceted needs of a patient.
All right, well, let's get to our part in caring for patients of sexual assault. What are key elements of the history, physical exam, and evidence collection in these cases?
Certainly, we need to make sure the patient has a medical screening exam prior to the sexual assault examination, and that we should approach these cases, of course, with trauma informed care, establishing, of course, a trusting relationship with the patient so that they're comfortable with the overall evaluation. And to do that, a few tips would be certainly to explain everything that you're doing before you perform it, and specifically asking permission before physically touching the patient and examining them. Choices should be offered, including choices on the pace of the examination, whether a support person may be present. And one other tip is that, we want to try and avoid repeat recounting of the event, since that can re-traumatize the patient and may even compromise a subsequent forensic interview. Now, when you do move toward the sexual assault examination portion of your care, you do have to, of course, obtain specific consent and be familiar with your local jurisdictions and requirements. Obviously, this is a very protocolized approach, and hopefully, every institution has the specific guidance on this. When deciding to collect evidence, that is generally guided by, again, local protocol, but previously there were different time limits depending on the areas of penetration involved. But now a lot of places are utilizing a 7-day window as a national accepted standard. Particularly in pediatric cases, of course, we have to consider additional expertise and support from child abuse pediatricians or a pediatric SANE. Ultimately, be familiar with your institutional protocol and follow it.
Well, how about evidence collection? That's going to definitely be a little different than what we do usually for specimen collection for medical reasons, right?
Yes, definitely. Certainly, you want to be thorough, a head to toe assessment to identify and photograph any debris, injuries, and collect any potential evidence. And so, if you do find any particular biological material debris, you can collect it using a two swab technique where the cotton applicators are lightly moistened with sterile or distilled water, rolled over the area, and allowed to air dry. If you do have any kept evidence, though, the other important thing to keep in mind is that we want to make sure there's a chain of custody for it. And so that evidence kit should remain in the physician's direct line of sight or securely stored before it is collected by law enforcement. Now, a particular subset of patients would be the concern about alcohol or drug facilitated sexual assault. And if that is suspected, you do want to also consider obtaining samples for tox testing. And so that is ideally the first available urine specimen, or you can consider blood samples, but really dependent again on your jurisdiction's policy.
Well, those are great reminders about the chain of custody concept, which we obviously don't think of with regular specimen collection. Moving on to prophylaxis and follow up care. What do we need to provide to patients post sexual assault?
Well, one thing that we have to consider, of course, with prophylaxis and empiric treatment for STIs is that testing specifically for STIs can be deferred if the patient is willing to undergo PEP. But if they do decline PEP, then we need to encourage testing, and that testing should be repeated to know for sure the results. And so, in terms of specific treatments, we're talking about treatment for gonorrhea, chlamydia, trichomoniasis, Hep B prophylaxis, and even consider HPV vaccination. And then specifically also for HIV PEP, this should be initiated as soon as possible, ideally within 24 hours and no later than 72 hours after exposure. And don't forget about certainly contraception should be offered. You can utilize ulipristal acetate since it is effective across a 5-day window and across BMI categories. But if it is not available, you can certainly utilize levonorgestrel. But one practical consideration is that ulipristal does require a prescription, whereas levonorgestrel does not. Don't forget, of course, to screen for suicidal homicidal ideation in our patients, and then also provide resources spanning across mental health, legal advocacy, etc.
Well, speaking of legal advocacy, what are the legal requirements when caring for patients after sexual assault?
I think the short answer is it depends because it does depend on where you practice. And so be familiar with your particular jurisdiction's requirements, which can usually be found on your state health department website or attorney general's website. And that also includes whether there's any specific considerations to mandated reporting. In addition, most healthcare facilities should have a written policy regarding caring for these patients, so be familiar with that. And then, particularly in sometimes challenging scenarios, would be intoxicated patients and how to consider their capacity. If there's any concern about their capacity, then we need to, of course, document our assessment explicitly. In the interim, medical care should not be withheld because we certainly presume that this is in the patient's immediate health interest. But the forensic evidence collection portion, though, will require their actual affirmation and consent.
Well, those are such great reminders. And thank you, Wendy, for going through this article. And thank you again to the authors for writing this. But such an important topic that has a lot of misunderstandings. I think the numbers that you shared were quite sobering to understand the spectrum of sexual assault and the fact that it doesn't fit into what some of us might think sexual assault looks like or the individuals affected by it would look like or be. Great review as well of the history and physical exam, as well as a reminder about evidence collection and the importance of a chain of custody, as well as checking what the legal requirements are in our particular location practice in order for us to comply with these needs. And then, of course, of the prophylaxis and follow up care regarding STIs and pregnancy. So, great reminders. Moving on to our critical ECG this month, we continue talking about how left bundle branch block complicates the diagnosis of acute myocardial infarction on ECG and the nuances of applying the modified Scarboza criteria. So definitely take a look. As for our clinical pediatrics this month, what do we have, Wendy?
It's actually a 7-week-old boy who was born at 37 weeks gestation, and they're coming in with URI symptoms, you think, or more concerningly, noisy breathing. And you find on your exam that they actually have some subcostal retractions, also some tracheal tug and stridor. Ultimately, you get several types of imaging, including a CT, that shows very severe narrowing of the lower trachea, with the airway tapering to 1 by 1 millimeter in diameter. That's really tiny.
I don't know what it should be, but definitely smaller than it should be.
Correct.
So, tracheomalacia is the most prevalent congenital tracheal abnormality, and it's often underdiagnosed or misdiagnosed because it's pretty nonspecific. And in patients with tracheomalacia, they can have increased risk of infections like pneumonia due to insufficient clearance of mucus. Another diagnosis that we must not miss in patients who present with noisy breathing, and we're thinking of tracheomalacia in, is vascular ring, which is a rare congenital heart defect in where the aortic arch and its branches encircle and compress the trachea or esophagus. Look at those images, very interesting. Moving on for our literature review this month, we're reviewing an article by Sue et al. entitled Resident Education and the Care of Patients with Criminal Legal System Involvement in the Emergency Department, published in Annals in 2025.
This is also a really helpful paper to review because we don't often really get dedicated training on this particular topic. And it can, of course, affect the patient's autonomy, privacy, as well as the potential for deviation from standards of care when we're managing a patient who is under the custody of the criminal legal system. And so, a few things that the article highlights that we should look further into if you're not familiar with, which would be your departmental shackling policy, including when medically necessary, when we can advocate definitely for removal of the restraints in order to take care of the patients. Don't forget that even for patients involved with the criminal legal system and under custody, they still retain rights to their confidentiality. And so we want to avoid disclosing protected health information to law enforcement unless it is medically or legally necessary. Now, if you are discharging one of these patients, you may have to consider their particular access to medications and appropriate follow-ups to ensure they have safe transitions and care. Sometimes just because a patient is under legal custody, get confused about their ability to make particular decisions, but really their custody status does not affect their informed consent or the right to decline care. So these are definitely things that are important for all of us to review, as well as to consider maybe providing dedicated curriculum to teach our trainees.
A great reminder and a great suggestion. For our critical procedure this month, we're talking about surgical drain stripping and removal. And we don't usually think that that's something that we need to do in the emergency department. I'm not sure about you, Wendy, but people show up to emergency departments for all sorts of reasons with a drain in place. Partly because they can't get to their doctor, they can't afford going back, they can't find transportation, but also because they've been part of a medical tourism situation where they had their procedures elsewhere and now they're coming over and they're like, oh yeah, my doctor told me to come to the ER in 7 to 10 days and have my drains taken out. And you're like,
Fascinating. So definitely increasing our scope in the ED, huh?
Definitely so.
Generally, we think about stripping or removing a drain if it is not putting out much, but it is good to check to make sure a low output drain is not putting out much because it is not functioning properly. So the first thing you want to do is empty the collection bulb and see if it holds suction, because if it is not holding suction, then that would be a reason and you can simply replace just the bulb portion of the drain. But if it confirms that it is working properly, then to specifically strip the drain, you want to hold the drain in place so you don't accidentally remove it unintentionally. And then use your other hand with your thumb and index finger to literally compress the drain tubing to quote unquote strip it, essentially creating increased suction throughout the tubing portion. One tip the article provides is to use a little alcohol swab because that can reduce the friction between your fingers and the drain tubing itself. This can ideally clear the tubing of any debris and help get it working more effectively.
Great tip. And just like you mentioned, Wendy, one of the benefits is that we decrease the risk of infection, but we got to remember that there got to be risks with that of, removing the drain, such as a retained foreign body or the development of a seroma. Obviously, if the drain gets dislodged, then we shouldn't push it back. And we should look for alternate ways to deal with that problem, such as placing a new drain if need be. For critical cases in orthopedics and trauma, we have an 11-year-old girl who presents with 1 month of atraumatic left hip pain that started after doing box jumps. That's why I don't do box jumps, they hurt. But anyhow, this girl had a limp and she seemed to favor her right leg and failed conservative management. So eventually she ended up getting an MRI as an outpatient and she ends up in your emergency department because they saw a Salter-Harris 1 fracture of the proximal left femur with medial subluxation of the epiphysis relative to the femoral neck, which is just a long description of saying SCFE, a slip capital femoral epiphysis.
It's a good reminder that SCFE is the most common hip disorder that affect adolescents, and it's important that we identify it promptly since delayed diagnosis can lead to a lot of badness, including worsening of the slip, avascular necrosis, chondrolysis, femoral acetabular impingement, and of course, osteoarthritis.
Plain x-rays are the first line of imaging, and they can show us physeal widening, irregularity, the displacement of the femoral epiphysis itself. And if it's subtle, we can also draw a Klein line. You can always Google how to draw that. But if that fails to intersect with the femoral head, then that suggests SCFE. Obviously, MRI is much more sensitive. We can see early edema and subtle slips. And it's useful when the clinical suspicion is high despite non-diagnostic x-rays. As soon as the patient is diagnosed, they should be non-weight bearing to minimize further slip regression and reduce the risk of complications. And the definitive management is percutaneous fixation, so surgery. Moving on to our critical image this month, we have found down in a parking lot. A 42-year-old found down, altered, with some signs of head and facial trauma. So of course you get a head CT. And you see that he has subarachnoid, subdural or epidural hematoma, and intraparenchymal hemorrhage, as well as right parietal temporal fracture. So clearly he didn't just fall, but something else happened. But the tricky part here is figuring out, is this epidural or subdural? Because that makes a huge difference.
As we know, epidural hematoma is often associated with temporal bone fractures and laceration of the middle meningeal artery, but a good portion actually can also be caused by venous bleeding, such as from the dural sinuses, and sometimes the actual source is unidentified. Obviously, for patients presenting with trauma, we start with a non-contrast head CT, as we did in this case, and the patient ultimately had a follow-up head CT that showed increase in size of what was then more apparent an epidural hematoma with its biconvex lens shape to it. Now, on your initial non-contrast head CT, sometimes you get some signs of the patient's risk of hematoma expansion, such as mixed density of the blood. On a contrasted scan, such as on a CTA, sometimes you can also see active extravasation. And in this particular case, ultimately, when you measured this expanded hematoma, it ended up being 40 cc's, which is quite large, as hematomas that are greater than 25 or 30 cc's are generally recommended to be neurosurgically evacuated, so they would need a craniotomy. In other scenarios, though, if the patient's clinical exam is poor, such as GCS is less than 3, or if there's other signs of midline shift or mass effect, such as even the finding of anisocoria, even if it's a smaller epidural hematoma, they should also under surgical evacuation. And then another scenario would be if this epidural is in the posterior fossa, since that is a much smaller space, even a hematoma of 10 cc's or more should be also surgically evacuated.
Moving on to our second lesson in this issue, bug bombs, identifying illnesses of bioterrorism. Thank you to Doctors Claire Charbonnet and Sharon Mace for writing this article.
Danya, maybe let's start with really what is biologic warfare?
So biologic warfare is the deliberate release of microorganisms with the intention of causing mass casualties, severe economic disruption, or widespread public panic. And the article has many interesting historical examples from the past, as well as a brief overview of the supposed transition away from the production of biologic warfare over the past few decades.
Interesting. So, what makes certain biologic agents higher potential as weapons rather than just a regular infection?
So, according to the CDC, agents are ranked into 3 categories depending on their delivery route, infectivity, latency period, mortality rate, and potential for public health impact. And those that are highest priority are considered category A agents. Those are anthrax, botulism, plague, smallpox, tularemia, and viral hemorrhagic fevers like Ebola, Marburg, and Lassa viruses. The tricky part about them is that initial cases of these category A illnesses are often misdiagnosed in emergency departments because early symptoms are nonspecific. And understandably, we're not going to maintain a high index of suspicion for like smallpox or the plague. And then the other really tricky part here is that in the context of a targeted attack, because of the nonspecific symptoms, the healthcare system doesn't only have to deal with sick people who have the actual disease, but then they're going to become quickly overwhelmed by patients who have nonspecific symptoms, freaking out about having said disease. And that is how it is considered a warfare.
That makes sense. Let's start with anthrax. How does it present?
So it depends on the route of entry. There's cutaneous, there's GI, but the one that's more relevant to this conversation is the inhalation, because that's the one that could be used in biologic warfare. And the disease course is biphasic. The early symptoms present in 1 to 4 days, very nonspecific: fever, chills, myalgia, fatigue, non-productive cough. And then days later, untreated patients rapidly go into bacteremia, respiratory failure, septic shock. What's pathognomonic about anthrax is hemorrhagic mediastinitis. So you can see that on X-ray as lymphadenopathy or mediastinum. And not pulmonary hemorrhage per se, it's the mediastinum that's the problem. The really scary part here is the latency period. It can last up to 2 months. Treatment is relatively simple, thinking like penicillin or doxy, but the thought here is that it's engineered for warfare than it's engineered with resistance. So you need something like a fluoroquinolone. And there's also antibody-based antitoxins, whether monoclonal or IVIG, from vaccinated individuals. The interesting part here about anthrax is that after decontamination, you're done. You don't need to quarantine patients because exposed patients are not contagious after decontamination.
Okay, interesting. What about something we heard in history books, the plague? What are their clinical features?
So you have the bubonic plague, where you have extreme lymph node edema until the node becomes hemorrhagic and necrotic. And then in 5 to 15%, there's the hematologic spread to the lungs, where you have the pneumonic plague, where it's pneumonia. With that, it's like rapidly progressive pneumonia. And if left untreated, they go into respiratory failure and septic shock in 2 days. Either form, bubonic or pneumonic, can progress to septicemic plague, which includes abdominal pain, subcutaneous hemorrhage, DIC, and what's pathognomonic here is digital necrosis. However, if you get to the digital necrosis part, then those are patients that are going to have really bad prognosis. The really tricky part with the plague is the identification, because many machines that we use nowadays in micro labs are not going to identify it correctly. And it's going to need specific testing that's only available in special facilities. Treatment is aminoglycosides like a streptomycin or gentamicin, but also maybe Cipro and Doxy. A really important thing to remember about the plague is it's highly contagious. It's not like anthrax. You do need to use isolation and wear surgical masks around the patients. You don't need negative pressure or anything, but we definitely need to do droplet precautions.
I see. Now, what about tularemia? How does this present and how do we manage this?
So there are 6 different clinical manifestations of tularemia, depending on the route of inoculation: oculoglandular, oropharyngeal, typhoideal, and pneumonic. In all reality, most people contract tularemia by handling infected animals, but you can have some outbreaks of inhalation tularemia from inhaling contaminated lawn clippings or brush cuttings. In all reality, when you're thinking biologic warfare, aerosolization is the best way to do that. Once bacteria has penetrated the skin or mucosal surfaces, they spread to regional lymph nodes, and then they cause suppurative granulomatous lesions with central areas of necrosis. So you have a lot of regional lymphadenopathy. And then after 2 to 14 days, you would have the rapidly disseminating systemic disease. You have the pneumonia, headache, rigors, cough, myalgias in the lower back. Some distinguishing features are like the pulse temperature dissociation, severe pleuropneumonitis with pleural effusions, prominent hilar lymphadenopathy. And the really tricky part here is that identifying it is challenging. So unless you're thinking about it, it's going to be really hard to find it. And blood samples actually don't work so well for cultures. You need like sputum, pharyngeal washings, gastric aspirates. But once you figure this out, treatment is not that complicated. It's quite similar to plague. And the good part here is there's no interpersonal transmission.
I guess that's one positive. All right, let's move on to what's in the news. Not as biologic warfare, but as an outbreak, viral hemorrhagic fevers.
So the family of viral hemorrhagic fevers is massive. but only if you have the features that we talked about earlier that would cause a serious threat as a biologic warfare. They're infective, transmissible, high mortality, and so on. But collectively, all these illnesses cause vascular endothelial damage that results in flushing, edema, petechiae, ecchymosis, hemorrhage, and ultimately shock. And the most infamous is Ebola, with its relatively recent epidemic in Western Africa. 99% of human cases are the result of direct person-to-person transmission. After an incubation period of around 3 weeks, patients would start these nonspecific symptoms, GI symptoms, dehydration. But then the final stage is that diffuse mucosal hemorrhage and multi-system organ failure that we talked about. And just like some of the other ones we talked about, most labs are not equipped for diagnosis. So if you're thinking of this, it needs to be sent to the CDC or the US Army Medical Research Institute. And therapy is supportive. There's not really something specific to treat viral hemorrhagic fevers with. There are some medications that were created for Ebola virus for a specific strain. The data's not that clear. You can use some antivirals for other ones, but all in all, it's mostly supportive. One thing we got to remember is that it's transmitted, again, person to person, percutaneously or through mucosal contact. Even physical contact with corpses can cause inoculation. And that's why we have to have strict contact precautions. And depending on where you are right now, you might be undergoing training by your hospital to remember how to manage that given the ongoing outbreaks in the rest of the world.
Well, thank you, Danya, for taking us through this lesson. Obviously, a lot of great pearls for all of us to brush up on these potential risks. As a reminder, biologic warfare, a big part of it is intention to not only cause mass casualties, but also widespread public panic. So that's a big piece of what we also often have to manage. And in terms of the highest risk agents that we went through, category A agents, also good to remember from CDC criteria, including anthrax, botulism, plague, smallpox, tularemia, and viral hemorrhagic fevers. We learned a bit about their variable presentations, our particular management, as well as differences on its contagiousness in person-to-person transmission risks. So definitely take a look at this lesson. And for our drug box this month, we're talking about fomepizole and acetaminophen-induced liver injury. And as we know, N-acetylcysteine, NAC, is really standard of care and the only FDA-approved antidote to acetaminophen toxicity. But fomepizole can also be used as an adjunct, as there are animal models and human case reports that suggest it has the potential to reduce the oxidative injury in this particular condition. But just be mindful that there has been no randomized controlled trials. To give this, you want to give a 15 milligram per kilogram IV loading dose, followed by 10 milligram per kilogram IV every 12 hours. And it's generally very well tolerated, so definitely consider this if you encounter one of these patients.
And last but not least, our Tox Box this month is aconite toxicity. And aconite is present in perennial flowering plants in Asia, Europe, North America, and mountainous regions. And all parts of the plant are poisonous, especially the roots. And the sources of exposure can be traditional Asian medicines that contain aconites, or, you think you're a forager and you found some chicory or celery in a mountain and then you eat it and then turns out it is one of the aconites. Or, of course, people would do that maliciously or purposefully. And the scary thing about them is that they bind to voltage-gated sodium channels and cause ectopy, QRS widening on ECGs, and neurological symptoms, specifically perioral paresthesia, which is the most common. It can occur quite rapidly. It can progress to seizures, ventricular tachydysrhythmias. The classic one is bidirectional ventricular tachycardia. They can also have AV blocks and hypotension, as well as GI symptoms. The pearl here is that for their ventricular dysrhythmia, you want to use flecainide. You can try the other things like amiodarone, magnesium cardioversion, but they're unlikely to be effective. And you can also consider VA ECMO for patients who have refractory ventricular dysrhythmias with hemodynamic instability. If they've been exposed, you can watch them for 6 hours. And if all they have is that perioral numbness, then they're fine. They can go home. But obviously, if they have any cardiac manifestations, then they are not going home.
Interesting. No foraging for me.
Well, thank you, Wendy, for taking the time to go through this issue with me. I've learned a lot. Our dear listeners, we hope you've enjoyed listening to us as much as we've enjoyed recording this.
We hope you find the Critical Decisions publication and our podcast always informative, often enlightening, and never boring.
Reach out to us on our social media. My handle on Instagram is @Dr. Danya Khoujah.
Mine is @Dr. Wendy Chang.
And until next time.
Bye-bye.